Welcome to the Protecting Your Nest podcast, providing a better path for as many people as possible is something I really want to do, particularly when it relates to chronic medical conditions. That's one of my life missions. This message should be heard by all, and particularly those who are more likely to succumb to those medical conditions like diabetes, hypertension, cancer, obesity, and so many more. But to reach those who are at higher risk, sometimes it's helpful to have someone with the right training and background so that the person on the other end of that conversation is fully engaged. Now, imagine living in a country where 14% of its residents are African American, but only 5% of the doctors are African American. Now, imagine again, in that same country, there is an obesity rate that's greater than 40%, but yet only 5,800 of its doctors out of 1 million doctors are board certified in obesity medicine. Today's guest and I are trying to help change this, and with our training in obesity medicine and our backgrounds will hopefully provide the necessary tools to help engage those who are still not engaged. Today's guest is Dr. Fatima Cody Stanford. Dr. Stanford is an obesity medicine physician scientist, educator, and policymaker at Massachusetts General Hospital and Harvard Medical School. She is a national and internationally sought after expert in obesity medicine who bridges the intersection of medicine, public health policy, and disparities. She's accomplished quite a bit over her years and has 5 degrees, 5 academic fellowships, more than 140 peer-reviewed articles, more than 300 lectures in the U.S. and worldwide, and has been all over media with even 45 mentees. So she's helping to teach the next generation. And of course, 55 or more academic awards and a 150-page academic CV. She's co-authored a book entitled Facing Overweight and Obesity, a complete guide for children and adults, and recently shared that she was promoted to associate professor of medicine and pediatrics at Harvard Medical School. And I was so excited to see that. So with that intro, doctor, I welcome you to Protecting Your Nest.
Thank you so much for having me here. It's a delight to be here with you today.
Absolutely. I can't wait to have this conversation. We've been following each other on LinkedIn, and I was so excited when you said yes to coming to the podcast. I really want to make sure my audience knows who you are. And let's get started how I ended my intro.
Absolutely.
And that's by, understanding, this promotion. You became associate professor of medicine and pediatrics at Harvard. And I'm not sure my audience fully understands what that means. So share a little bit about what that promotion is, what's that role, and more importantly, what does it mean to you personally to have achieved that?
Absolutely. Well, first of all, I think it's really complicated when we begin to talk about this idea of academic medicine. They're like, but aren't you just a doctor? Like, what is that? What do you mean you're a professor? Do you teach and you do other stuff? And yes, so the answer is I have like 18 jobs. For those of you who know me, I really do have about 18 jobs. But let's talk about what if I didn't have 18 jobs, if I were just a pure academic person, what that means. It means that you are a physician, and for me, I'm a physician scientist. So there are a few things that I do. I do teach medical students, residents, and fellows. So once you finish, medical school, you do something called residency, and then if you subspecialize, like I did 3 years of obesity medicine fellowship, and then I finally came on faculty. What that means is now I can then go and educate those coming behind me, kind of in perpetuity, making sure that I create a path for them. Many people don't spend their time in academics in medicine. They either will go into private practice or some type of group practice. Probably many of the doctors that you see aren't in academics and so don't have this kind of additional work to do of teaching, educating medical students, residents, fellows, and having them, wanting part of you at really all times of the day and night, which is what I find with my mentees. And I understand that because that's exactly, how I was. Here at Harvard Medical School, we do things slightly differently than most medical schools in the country. And once you finish and you initially come on faculty, we start at the level of instructor. Most medical schools throughout the country, I would say on the order of 95%, there are a few others that kind of follow the Harvard pathway, will start you immediately at the level of assistant professor. But for us, we started instructor and then need to get promoted to assistant professor. And then you get promoted from assistant professor to associate professor. And then finally go to what's considered to be the top of the top, which is a full professor. The reason why this makes a difference is because the higher you climb in this academic rank, the more power you're able to have in terms of influencing conversations surrounding chronic diseases that I treat, like obesity, or issues that are really germane to a lot of my work, which is inequity, disparities, diversity, inclusion, for example. And those things are extremely important. In terms of who makes it there, if you just look at full-time faculty in medical schools throughout the United States, only 4% of medical schools, of people in medical school faculties throughout the United States are women from underrepresented groups. And so what do I mean by that? That would be Black or African American, depending upon which terminology you like to use. Latinx, those that are Native Hawaiians, Pacific Islanders, all of those populations, if we put all of those together, only 4% are women from those groups. So you can imagine that when we start looking at the different levels of where you can be, here starting at the instructor level. And so just think our instructor level here at Harvard is the equivalent to everyone else's assistant. Our assistant is kind of the equivalent to everyone else's associate. Our associate is the equivalent to everyone else's almost full. And then our full, I was talking to you before the start of the show, is that we have many people that, may win a Nobel Award or Nobel Prize and then finally become a full professor a year or two later. So it is a big stepping stone. I'm one of those people that likes to get to the end. I talked about this as a penultimate level, which means, before that final level, or the most senior level, which is the full professor level. But it does give us influence. For example, there are a lot of roles and positions in medical schools that you aren't even eligible for at the instructor or assistant level. There's some that you're not eligible for until you're at the full professor level. And so the higher you climb, the more influence that you have. And as was mentioned at the outset of the show, only about 5% of physicians in the country look like me and you. And so that's problematic. We know that the number of Black physicians has only changed by 4% in the last 120 years, not 20, 120 years here in the United States. And when we look at who's most likely to provide care to patients of color, patients in underserved communities, it is by far racial and ethnic minorities. The American Association of Medical Colleges has studied this question year after year after year. And year after year, Black medical students say the communities they want to serve are ones that look like ours.
Wow. Well, thank you I'm so happy that was the first question, because I don't think that the average person understood, first of all, what it meant to achieve what you just achieved, but this idea of not having a lot of people that can speak to the population about topics that are so critical. So I really, again, celebrate what you've achieved, and I hope others, the little baby girls and boys out there, rather they're African American or any other culture, are inspired by your story. So thank you so much. And I'm also excited about, taking care of people with obesity. I just felt like it was a way to focus on the thing that probably will have the biggest impact. And not that you can still be metabolically unhealthy and be thin, but I knew that would make a big impact. So I got into obesity medicine to really reach more people and to maybe, if possible, reverse many chronic diseases. So my question to you, what got you passionate about obesity medicine and led to you focusing in that area?
Absolutely. So, my journey to obesity medicine, I would say, started a little over about 21, 22 years ago when I was completing my first master's, which was the one in public health at Emory in my hometown of Atlanta, Georgia. I live in Boston, but, I obviously will never claim Boston as, my birthplace and birthright. That belongs to Atlanta, Georgia. When I was there at Emory's Rollins School of Public Health, a lot of the projects, actually every single project I was studying, was looking at overweight and obesity within the Black community. For those of you who are familiar with the predominance of Black Americans that live in the Atlanta area, we have a very, very high percentage in the Atlanta area. And so there were three main projects that I was involved with while doing my MPH. One was called Healthy Body, Healthy Spirit, which was a project specifically in Black churches in the Atlanta area. That was, one of my first forays into doing work out in the community under the direction of a gentleman by the name of Ken Resnickow, who's now at the University of Michigan. He also had another project called Go Girls, which was particularly focused on overweight and obesity within adolescent girls that were Black. So obviously that was right down my alley, as having been born and raised and growing up in Atlanta. I felt like I could identify very well with that population. And then finally, the third project was looking at the Wic Program. That's the Women, Infants, and Children's Program, and particularly looking at Blacks in that program. And so I noticed that there was a common theme between all of these. It was really to focus on weight status, metabolic health, meaning how does your weight affect things like you developing diabetes or heart disease or sleep apnea. And so I, got very interested. And I also was really interested in understanding why is the group that is most likely to suffer, particularly Black women, what is that all about? Like, it's not just about, how much they're eating or exercising. There has to be some other things. And so fast forward many years, I initially thought I was going to be an orthopedic surgeon, which is why you might see some of those qualifications in research, and then did residencies in internal medicine and pediatrics. And really it was between my first and second year of my Med-Peds residency, when I was on call in the pediatric ICU, that I was trying to figure out, like, what am I going to do with my life? Obesity medicine wasn't really a thing at this point. I was a little kind of early, but then I had just intubated 3 kids, which in the ICU, which meant that I wasn't going to sleep that night while I was on call. I went and sat at the nurses' station so I could be available for the nurses and the respiratory therapists to ask me whatever questions. And I went up to our favorite search engine of Google, and I type in obesity and I type in medicine. It's about 2:00 in the morning. And the Harvard Fellowship in Obesity Medicine pops up. So I was like, what does this even mean? Called my husband at the time, and it's like, hey, there's this Obesity Medicine Fellowship in Boston at Mass General and at Harvard. He's like, what does that mean? You need to do some more research. I was like, okay, fair point. So I went back, did some additional research, reached out to the program director at the time, told them, I'd like to come and rotate as a resident. They were like, well, we don't have that set up. And I was like, well, we have enough time, I think, to make that happen. And was the first person to rotate in obesity medicine as a 4th year internal medicine and pediatrics residency, and then came and did 3 years of dedicated work and training on how to care for patients with obesity. And it was after that I came. I didn't know I was going to be staying. I thought I was going back to Atlanta, but obviously a decade later, I'm still here in Boston. So I know that's a longer story, but I think it helps you to understand kind of my vantage point or viewpoint with where my introduction to particularly Black women, Black communities, looking at the disproportionate impact of obesity within those settings, and then me as a Black woman trying to understand how can I play a role in helping to elucidate why we see the disproportionate impact in communities of color, but treating the community at large.
Wow, you're preaching to the choir when I think about how broad you've made this journey, and even though I'm more in a low carb community, I was so happy that I came up with the metabolic health doc, protecting your nest, and thinking about all the various aspects, because what I found is that you really can't help people if you don't address all those other things. If you just focus on diet, if you just focus on exercise. So I think that's really insightful, and I'm happy that you found obesity so you can help so many people. But it is a big problem, and a lot of people are not as familiar with its prevalence. So if you think about the work you're doing, and I'm sure you speak about this often, talk a little bit about how common obesity is in society today.
Absolutely. So first, if you don't mind, I'm going to just explain why I'm talking about obesity as a disease. I think that's really confusing to people. They're like, what do you mean it's a disease? Like, I've never heard of that. What is this doctor talking about? So when we talk about obesity being a disease, it means that there's some type of pathophysiology, something going on in the body that's leading someone to have more weight than another person, even with doing the same behaviors, for example. And so I just want to say at the outset that the organ that really regulates our weight is is our brain. Okay. And our brain tells us how much to eat and how much to store, much like it'll tell us when we're thirsty, right? Like we don't all get thirsty at the same time or all need the same amount of water to quench that thirst. But when we get thirsty, we go get water and we're like, okay. And then we stop drinking when our brain's like, I've had enough. It's not like a thermometer that particularly says, oh, you should drink 1.2 ounces to fulfill this. Obviously, if you're in the hospital, we start calculating things like that. But in terms of just our normal daily functioning. So I just want to start with that.
Yeah.
And then I also want to set up the idea that obesity is not a person's fault, which a lot of people, will go toe to toe with me on that. But I want you to should bear with me in terms of thinking about, this idea of obesity as a disease. So let's talk about its prevalence, which was the question you asked me. But I wanted to just talk about what it was before we talk about its prevalence. Based upon something called the National Health and Nutrition Examination Survey, which is a big survey where they actually go out and measure individuals throughout the United States to determine weight status. The last really intensive one was done in 2018, predating something we call COVID-19. Where we found that 42.4% of US adults have the disease of obesity. Okay, so we're talking about over 40% of individuals based upon 2018 data. Now I want you to fast forward and recognize that we're in 2022, and then recognize that we're also in the junior year of this COVID-19 pandemic, where we have had even a greater shift in obesity rates. So I would, like if we were to do that survey and if we didn't have Omicron variant or other variants out there, I think we would see that these numbers are actually significantly higher today than they were in 2018. Okay. Just want to give that. Now, in terms of kids, because I see kids and adults, we're talking about 20% of the pediatric population. And that would be anyone between like the ages of 2 and 20 that have the disease of obesity. Now, I want to hone in on the disproportionate impact of communities of color. I want to focus in on Black women because that's the vantage point that I live my life, right? So if we're looking at Black women, about 60% have the disease of obesity. And another 20% have overweight, which means 80% of Black women have overweight and obesity. Okay. That's something we can't ignore, but we've been ignoring it for so long. And when I say we, it's the collective we, not just us as physicians, it's the population at whole. Any of you that are listening today, it's government, it's industry, it's business, it's education. Every single group has neglected those numbers that I just gave you and just dismiss it as, oh, that person did something wrong. So we're saying half the population did something wrong. Are we saying 70%? Because when we look at the number of individuals with overweight and obesity, we're getting into numbers like 60, 70%, even without taking the racial ethnic differences. All of those people just did something wrong and we just don't need to care about them. And then we've neglected the idea that if we treat the obesity itself, much like you said earlier, we get a chance to have downstream impact on multiple diseases. And one of the key things I love, particularly on the patient side of things, that's another job I have, you guys. So I actually see patients. On the patient side of things is that I get to delete diagnoses all the time from my patients. There is no other area of medicine where we're deleting diagnoses. We're just adding. We just keep adding. And then you're like, oh my gosh, my problem is I have 20 problems. I had no idea I had all of these problems. But for me, I take pride in having my patients to try to figure out how to build them. I say history of obesity. Their obesity is no longer present. History of diabetes. Ooh, that went away. History of fatty liver disease. History of sleep apnea.
Right.
And the list goes on and on. We know that obesity leads to 200 plus different diseases. We treat all of those diseases, but nobody's treating the obesity in a real concerted fashion. I would say that there's some of us that are doing this, but the number is so minuscule compared to the population that has the disease.
Yeah. Well, I'm just happy again that the obesity training organizations are here to help us because I don't know that I even knew that your gut bacteria could affect your weight until I trained, right? In
Yeah,
obesity
absolutely.
medicine. It blew my mind. And
It's
also
mind-blowing,
learned a
right?
lot.
It is
Yeah,
mind-blowing.
it's mind-boggling. So, and then that way we can kind of think about the next thing I wanted to touch on, which is the bias question, right? So, man, so many people who are living with that disease called obesity, and I appreciate you helping to educate us about how to think about it.
Mm-hmm.
There's a lot of bias
Mm-hmm.
towards folk who have this disease called obesity. And unfortunately, many of us don't feel we personally are biased towards others. And I know in my training, again, they help us to understand that when I got board certified in obesity medicine, part of the conversation was to educate those clinicians getting that certification and training that you may have some bias yourself, doctor, and you need to look in the mirror. And I did hear you talk previously about a personal story about bias, as you shared a story about a train conductor. And even
Oh, this
as
is
I
one of
think
my
about
favorite
that,
stories. I didn't know you were going to go here. I'm so excited. Okay, but let's go there. I'm
yeah,
ready.
okay, you love that. Let me
Yeah.
tell you something that's funny about as I think about this question, I bring up a train. I just saw Regina King in that
Mm.
Western. I don't
Yeah.
know if you saw it yet,
I haven't
right?
seen it,
And
but I know about it.
I was so proud, and I didn't even know there were stories to tell. But in that Western, the train, our a lost hero, our Black Panther, they had his name on the train. So for those who haven't seen it, when the train goes, when they're walking by the train, they honor our Black Panther
Oh,
who passed. And I thought that was so. I just thought
that's
about that this
interesting.
moment. But having said that, I think hearing that story about the train conductor is a great way to talk about bias. So, why don't you share that story so my audience can hear it?
Absolutely. Well, this is one of my favorite stories. It touches my heart even as I'm telling it to you. So you've heard it before, which means that I'm not shy about using this story because I think it really reflects how bias really plays out. So when I first moved to Boston to do this 3-year obesity medicine fellowship, I lived out on the North Shore, which basically I had to take a train that's like an Amtrak train into the city where you get to the regular subway, which in Boston we call the T. So I would take this train, and it's called the commuter rail. If you live in New York City, it's something like the Long Island Railroad. This is the kind of thought process behind it. But every morning at 7:13 a.m., I would take this train into the city. When I would get on the train every morning, I would see this gentleman who had severe obesity, very severe obesity, who was one of the conductors, and he'd move up and down the aisles. He was always taking the tickets, doing all this stuff. And I secretly wanted him to be my patient, but I thought it would be a bit presumptuous of me to go over and hand him my business card and be like, hey, I'm an obesity medicine doctor, come see me. So I didn't do that, although secretly I did want to because I felt like I could help him. I saw how much, he was moving and mobile and doing all this stuff, but I also saw that it felt burdensome on his body. So, I just watched him passively as one of the thousands of passengers on the train every morning. I'm sure he didn't even probably notice me. It's just so many people, most of the time standing room only. Fast forward about 3 years ahead, maybe. I can't remember the exact number of years, but let's say about 3 years. And I walk into my office and he's sitting there. And I exclaim, oh my gosh, you're the guy that's the train conductor. You're on the North Shore and you did this. And I want you to, so I was really excited. But I wanted to note that this gentleman who was 45 years at the time, about 45 years old, had his mom with him. Now, I don't know many men that would, at 45 years of age, unless they have some type of deficits, that would bring their mom to their doctor's appointment. They don't bring their spouse. Well, maybe they'll bring their spouse, but that would be the only person potentially. But this person had brought his mom. So I sang all this stuff. I'm so excited that he's somehow here in my office of all the places he could be, and he's seeing me. And he's kind of looking, like kind of happy, but he's confused about he had no idea, obviously who I was. I knew who he was. And his mom starts to cry. And she cries for about the first 8 minutes of my hour-long initial visit. And she says to me the following. She says, Dr. Stanford, you're the first doctor in his life that ever believed that he did anything active. You came in, you start talking about his activity and how you saw him for more than just his size. The reason why I'm here at this appointment was I was coming here to convince you that he's active, he's eating healthy, he's doing all of these things, but he has struggled with his weight since day one. And you were the first doctor that I didn't have to convince of that.
Mm.
Now, I can tell you that when he first came into his first appointment, he weighed 550 pounds. As of now, in our chronic care, we've been able to get him to 300 pounds. Now, let's talk about how bias would play out. If you were to see this gentleman walking down the street with 300 pounds, even though he is a taller individual, probably about 6'3", 6'4", somewhere in there, you would still say, this guy's let himself go. He needs to be doing better. With all of the optimal therapies we have available anywhere in the world, we were able to get him from 550 to 300, and that's where he's been able to stabilize. Now, I will tell you that he has none of the chronic metabolic diseases that he had when he first came to me, even at this weight of 300 pounds. But we would presume, with no knowledge of what his story was, that he's lazy, doesn't care about himself, careless, he's passive. These types of things, unmotivated, without knowing that this guy is probably one of the most motivated gentlemen I've ever met in my life. And I can also tell you that I know his mom trusts me now because she no longer shows up at his appointments. So I just think that story really has a lot of different layers, a lot of things you can unpack. But what it says is that this judgment was so strong that this mom thought she had to go to the appointment, not with her 5-year-old or her 10-year-old, but her 45-year-old, to convince this doctor, who happened to be me, that, look, my son's voice matters. Let me explain. He has struggled and he's been doing all the right things, but something's not working. So that's the story.
Wow. I think I've done shout outs to moms on my podcast, but I definitely want to take a moment
for her, right?
And do a shout out to the moms who are standing by us, and we'll be their babies forever. Sure. And just hearing that story again is inspiring. And again, it helps us to understand that we all have bias that we need to work on. We also have learned when we got our training that words matter. And the words we use matter. So one of the words that we don't like that I want to speak about briefly with you is that word fat. The word fat can cause pain, and it's funny because your name, right? The first three letters, right?
Those 3 letters at the beginning, right?
You were destined to be an obesity doctor. I mean, what's the chances of that?
Yeah.
So the first 3 letters here. So my question, when people think about you, right, and they think about the work you're doing, they would assume that you wouldn't struggle with words that we're trying to educate people about. So I want you to tell the story of how you discovered that even you had to think about that word and how it may have been used when you didn't know it was being, so talk a little bit about that as well.
Yeah. This is a point where I make myself vulnerable because I'm supposed to be this, Harvard educated person with all these accolades. But this is when I will bring it down home and talk about bias and my own biases. And I'm going to take you back to me at the age of 5. So I won't tell you how many years ago that was, actually, almost 40 years ago. But what I will say is I actually was at a obesity conference. I won't name which one. And a woman who I've known my whole life, let's say since I was about 3 or so, came up to me. So she's a physician also. And she came up to me, and I'm a talker. So if you guys ever see me at a conference, which I guess I don't know when those will happen again, but when they do happen, you can find me in the hallway talking to someone, because that's where I'm making my connections. I like to be talking and engaging with people. I have a harder time just listening into a lecture. That's just not my thing. I can give the lecture, but I can't really sit and listen to one. So anyway, so she comes up to me and she says, "Oh, Fatima, I've been wanting to say something to you." But then other people see me and then they start talking, and then this goes on for about 30 minutes until finally she corners me. And she says to me, "Fatima, I don't know if you've recognized it, but I've always been relatively standoffish towards you." And so I'm kind of a little intrigued here because I've known her for most of my life, and I just assumed that was her personality. So, I mean, if you've known someone for over, almost 40 years, you presume that's just their personality type, right? And so then she goes on to say, well, there's a reason why I've been that way. So I'm recognizing that maybe this isn't how she is. It's just the way she is towards me, and I just didn't recognize it. She says, well, when we were in dance class at Spelman College, when we were young kids, you came up to me in class and told me I was fat, and you walked off. I don't recall this. And when I tell the story, even when I told my parents and my husband, etc., they were like, "Oh, well, you're only 5. But she was remembering this almost 40 years later. And she had been wanting to tell me this for many years. And she says this, and this is what really stung, in addition to me finding out the bias that I had towards her, was the following. She says, well, Fatima, I thought, and I said to myself, that if you are capable of change, anyone is capable of change. Now,
Mm.
that burned me as someone I would say is probably the most outspoken advocate for against weight bias and stigma here in the U.S. and around the world. To hear from my colleague, who's a physician, that I am like the most villainous of them all, and if I'm able to change, then anyone else is, was humbling and eye-opening. It was at that time that I really tried to figure out, like, at what age do people really begin to show signs of weight bias, and what's the average age? And a lot of actually the data shows that at 32 months of age, Dr. Hampton, that 32 months of age is when people actually begin to really demonstrate signs of bias. So 32 months. So I was 5. That's older than 32 months if you don't know how to do the math. And so then parents often will say to me at that point, I'm putting on my pediatrician hat, well, Dr. Stanford, I don't say anything bad against, people that have excess weight. They don't usually use that words, but whatever words they use. And I say, well, it's not just what you're saying, it's also what you're not saying.
Mm-hmm.
So let's say you're watching a television show and everyone that you compliment are all people that are lean. Oh, look at how gorgeous she looks in that dress. Oh, she's just amazing looking, or he looks fabulous, or whatever it is. And you don't say anything negative about those people that have a high degree of excess weight, but you just don't say anything at all. The messaging that's coming to the individual, your child that's sitting there with you, is that, oh, these people must not be as valued, because mommy and daddy always say very positive things about the people that look like this and never the people that look like this. And so, when we look at the higher likelihood of having bias, it's influenced by our parents, our caregivers, whoever those people are that are there at the beginning parts of life, they help shape it. Now, a lot of people have quote unquote embraced this word of fat. And I put quote unquote, because there are certain communities like the Health at Every Size movement, for example, that have embraced this word. But I want to challenge that quite a bit. If you're on the playground in dance class, like I was, and someone comes up to you and says you're fat as a child, you never take that as a compliment. That is not seen as a compliment ever in those settings. And the trauma that I caused to my colleague, who I consider to be a friend also, is something that's lived with her and has shaped how she views the world. Now, you can decide later on that you want to embrace this word, but let's think about it. We know that those things that are happening on the playground, at playtime, those types of things, when they're being stated, unfortunately, to cause harm to an individual, whether or not they remember it, like myself. Not a great word. So we want to talk about patients having obesity. We want to eliminate the word fat. We want to eliminate the word obese. Person has obesity. Obese is a label. Obesity is a disease. And the other word I want to just get rid of is morbid as it relates to obesity. We don't call it morbid cancer. We don't call it morbid COVID-19. We don't call it morbid heart disease. We don't call it morbid anything else. Yet we call it morbid obesity, because even in the language we use to talk about obesity, we have these stigmatizing words. So I just want us to be cognizant. You guys could tell I live in downtown Boston with all of the sirens. But I just want to also acknowledge that we have to be thoughtful about the terminology that we use even to explain obesity. And we don't call it morbid anything else, but a lot of other things kill people. But it's only obesity that somehow gets morbid attached. So I want us to remove that attachment also.
Thank you for that. And thank you for bringing up morbid obesity, because, in my world of population health, HCC coding, and if you don't bill with morbid obesity, you don't get the full credit.
I'm going to challenge you on that. If you look at the ICD-10, if you look at severe obesity under, like, let's say a system like an Epic, Cerner, Citrix, it's the exact same ICD-10 code.
Got you.
So you don't have to
that's
use
very
morbid,
helpful.
right? So I actually delete from every patient that comes to me from primary care. If they come in and morbid obesity is on their chart, I will delete that diagnosis. For any of the docs that you're wondering how your chart got changed, I am the one that's doing it. I will continue to do it. I hope that you will consider making so that you don't bill that way, so I don't have to go and change it and do your work and my work. You can bill for severe obesity, and it's the exact same ICD-10 code, which means it gets the exact same thing.
That's huge.
Yeah.
I don't need to talk anymore. That was huge for me.
Yeah.
So thank you for that,
Yeah.
because I think we will have some clinicians. I will talk to my organization, because I don't know that that's well known. And we've been trained morbid obesity, and it drives me crazy. And so thank you for that. That's going to be
Absolutely.
huge. One thing I want to ask you about is the book I introduced in the intro, Facing Overweight and Obesity. Just want to get a feel for who is that book meant
Sure.
for, and what would people learn if they got it?
Well, first of all, you're going to go to Amazon and you're going to purchase it now. Don't you feel like you want to do that?
Right.
So no, it's obviously available as a paperback. It's available on as Kindle under Amazon, both here in the U.S. and around the world. It's called Facing Overweight and Obesity, and the next part of the title, I think, will tell who it's for: a complete guide for children and adults.
Yes.
As someone who cares for patients between the ages of 2 and 90, I have to think about the entire population. I have multiple generations under my care, some where I'm taking care of 3 or 4 generations. So I'm thinking about how can I write a book that comprehensively addresses issues that pertain to all of those groups. And so if you are anyone between the age of 2 and 90, which I would say, unless you were Betty White that lived to 99 or something, I would say this book is for you, because all of us have family, friends, even if we don't ourselves have obesity, that do have this disease. And we might recognize, wow, there's just a lot I don't know about it. And so this book is pretty comprehensive. I think that I found from people that are physicians that they even get some key pearls out of this if they're like starting their journey and learning about obesity. Some of the words will be technical when we talk about things like obesity related diseases like obstructive sleep apnea, et cetera. But we also talk about things like bias and how media influences bias and how that can affect individuals. So we really, take it into many different areas to get people to understand the impact of obesity on ourselves, how you can get involved in maybe clinical trials if you're looking at that as a potential strategy to kind of learn more and get more involved and get more engaged. So we really we do a lot of education. All age groups are included. I really think that, it's over 300 plus pages. So it's a lengthy, but I can't remember the exact length because I haven't looked at it today. But that's what we were going. So it was myself as an obesity medicine physician, and the other 2 authors that are listed on the cover are both psychiatrists. So when we're talking about obesity, we have to recognize that this disease is not just one that manifests in the physical. There's some huge mental health components associated with obesity, much higher rates of suicidality, for example, in this patient population, disordered eating, et cetera. And so we delve into some of these issues also.
That's very helpful. I just want to make sure, and we'll have links in the show notes, of course, to the book, because I want to make sure people have an easy way to get to the book. As we kind of get close to wrapping up, I do want to touch on, the COVID-19 pandemic, and as you know, it's kind of uncovered other pandemics that were here all along. And I know you talk about 3 pandemics. So just briefly talk a little bit about what the 3 pandemics are and how they're interrelated.
So I'm going to drop another charm. I mean, I recorded a TED Talk on what I call the collision of 3 pandemics. And those 3 pandemics were COVID-19, which I think all of us can agree has affected our lives, obesity, which has become the number 1 risk factor for both sickness and death related to COVID-19, and then racism. And so you might be like, well, gosh, did she just really just pull 3 things out of the hat and put those together? Well, let's talk about how they work together. We already talked about the prevalence of obesity. It is the most prevalent chronic disease of our time, hands down. Nothing else comes close. Number 2, we can agree that COVID-19 has affected us greatly here in the US more than other countries, which is devastating because we have resources that other countries don't have, and somehow we haven't navigated the pandemic as well as others. And during the course of this pandemic, I would say that we've had turned a significant spotlight on racism. With the murders of George Floyd, Ahmaud Arbery, Breonna Taylor, we saw people coming out in mass, not only here in the US, but around the world to really illuminate not only their individual murders, but also to illuminate the disparities that come with being Black and Brown, not only here in the US, but everywhere. And so we really put a spotlight on all three of these simultaneously. We start seeing institutions, not just in medicine, but throughout the entire community, deciding to name DEI, which is diversity, equity, and inclusion leaders, and to at least often pretending like they were addressing issues surrounding racial equality, and assuring similar levels of success and progress for Black and Brown communities here in the U.S. I get really upset about showmanship. This is idea of like naming it and pretending like we're doing something when really we just want things to remain the same, because when you begin to elevate those that have been disadvantaged, it often takes away power from those that have had advantage from not allowing those like me to move up. So I just want us to call it out and state that these are things that I'm very vocal about. So this is would not come to any surprise of anyone that's ever met me that I would say that. But these are the things that we're seeing. And so the collision of these things have led to major issues. The disparities we saw in terms of both sickness and death in communities of color, and still continue to see, is heartbreaking. But it goes back to seeing the higher prevalence of obesity in these communities, seeing how racism and exposure to racism, for example, in the Black Women's Health Study, the largest study ever done in Black women, shows that, both chronic and just episodic exposure to racism increases stress, which increases the storage of fat tissue, what we call adipose, and that leads to worse outcomes. So, it's a collision that it was always there. Maybe those two things were there, obesity and racism. But when COVID came out, we really got a chance to see all three of these rear their ugly head.
All right. So I'm going to wrap my last question into two. I'm cheating a little bit, but I want to just make the last question two questions.
Okay,
the first is this idea of, one size doesn't fit all. That's something I've learned. That's why I call myself metabolic health doc instead of low carb or keto or whatever, right? Because I do believe that I have patients who are vegetarian, they're doing just fine. So the first question is, when you make recommendations for diet, do you take that kind of approach, or do you tend to lean? I'm in a low carb community, so because I lean low carb restriction, but I recognize. So what's your thoughts on diet?
I wouldn't say I lean one way or the other, although, being one of the experts just in the U.S. News World Report's best diets, I think people probably would say that, people might assume that I lean one way just based upon how the rankings came out with the best diets,
right.
As the first Black to ever serve on the panel. I would say that I don't lean one way. I literally state the following to my patients. I say, I want you to have lean protein, whole grains, fruits, and vegetables as your predominant source. Now, lean protein, I didn't necessarily say plant-based, although if we're looking at longevity, plant-based tends to be the way that most people should possibly go. I said lean protein, whole grains, right? Whole grains, if you, are someone that has a gluten sensitivity or celiac, you can still do whole grains. You just have to pick the grains that are right for you.
Right.
Fruit, we know what fruits are fruits. Fruits are fruits. And, you have to, maybe do those differently depending upon what your disease states are, maybe lesser of certain types if you have, let's say, diabetes, for example. And then vegetables. We know that vegetables are never on the bad list of anything. So I don't necessarily lean one way or the other. My goal is to find what the patient will do and what they'll do for the rest of their life.
That's right.
So, for example, if we're looking for someone that's vegan and I all of a sudden tell them they need to be eating fish every day, and they're kind of like, well, but I'm vegan. That won't work for them. They've been vegan for 15 years and you're telling them they need to go and get some salmon, not the best strategy for them, right? So I tell them my goal is to help them fit with what works for them. Similarly, for physical activity, I love exercise. You guys can go find me doing some crazy high intensity stuff. That's what I enjoy. But just because I enjoy that doesn't mean you enjoy that, or doesn't mean any of my patients enjoy. So what we have to find is what works for you to make your health the healthiest for the longest duration.
That works. So one thing you're going to do to protect your nest for the next year, anything in particular you're focused on?
This is so the one thing I would say I struggle with is not any of the things I've talked about. I would say it's about taking time for self.
Yeah.
I am so much to so many people. I mean, yeah, I get in my exercise. Everybody knows that. My patients, I think, probably get annoyed with me, or maybe they don't. I don't know. They keep coming back for years now. So, but it's about literally taking that time to just be and that kind of
Yeah.
mindfulness that allows you to de-stress. I'm one of those people that packs every second of every day. Everybody knows I work 80 to 100 hours a week. That is me. And that's been me since day one. This is not a new me. And so I know that I can't change that whole me, but I can maybe find some slithers of things that are a little bit less me, which are those things where you're just being. Not something I do well. I will not pretend to even be at the basic level yet, but it's something that I think is crucial with someone that is charged and moves at the speed that I do and really has fires on all cylinders literally all day, every day.
Yeah.
Yeah.
Yeah. So thank you. Well, that's why how you became the associate professor of medicine and pediatrics at Harvard, unfortunately. So I
Yeah.
definitely appreciate your comments as we wrap up. And I definitely want to thank you, Doc, for your insights and the work you're doing and all the help that that work will then lead to help those who are suffering for obesity. So we applaud you, we support you, and we appreciate you. So thank you very much. Okay.
Thank you. Thanks for having me.
Absolutely. And for those who are listening, I think that we learned a lot today about bias and I hope people are more comfortable hearing this conversation to know that there are doctors out there who are getting training to help us better understand how to help you. I really appreciate you guys who are checking in on the podcast and the YouTube channel. We appreciate your support. And I promise to continue to bring great guests like Dr. Stanford to future episodes. Reminder, we do have a documentary that I was in with Vinnie Tortorich called Beyond Impossible. So for those who are wanting to learn more about that information, check that out. It's on Amazon and a few other places. But as I always say, as we wrap up, continue to take care of yourself, be safe, be well, and continue to protect your nest.